Job is to talk to you about intraabdominal pressure and ARDS. It's a very common relationship, as a matter of fact. Here you see the relationship between the days spent in the ICU and the incidence of increased abdominal pressure. And you see that day by day, the chance of your patient converting into a patient with increased abdominal pressure increases substantially, up to 60% of the cases after 1 week. So, increased abdominal pressure is an important pathophysiological condition, and we should be aware of it. Normally, palpation of the abdomen is not enough to get a clear idea of the real pressure in the abdomen. It's much more profitable to measure it, and measuring it is very simple indeed, since most of our patients have a urinary catheter in place. I wonder how many of you actually do measure abdominal pressures often, but I do not have time to spend in explaining how to perform this measurement. It's very simple. It has been published many years ago, and the relationship between the pressure measured in the bladder and the real intra-abdominal pressure is pretty close. So we can take the urinary bladder pressure as a good measurement of the abdominal pressure. Why is abdominal pressure important? I think that we all know why it is important, but I will go back to a few characteristics of the so-called abdominal compartment syndrome, which is the pathological condition that comes from a high abdominal pressure. High abdominal pressure is anywhere higher than 12 millimeters of mercury. First of all, we have bowel ischemia, we have decreased perfusion of the abdominal and thoracic organs, we have decreased cardiac output, increased central venous pressure, increased intracranial pressure, and most of all, in dysfunction of the lung. Most of these patients present with ARDS before they have abdominal pressure compartment syndrome, and in many of them, the presence of the abdominal compartment syndrome worsens the lung dysfunction. This is an artificial system to increase abdominal pressure transiently in patients, and we have been performing a few years ago CT scans at different abdominal pressure achieved by inflating a CPAP balloon over the abdomen. And you see here the CT scan taken at normal intra-abdominal pressure and at end expiration with PEEP, mind you. Average PEEP here was 10 centimeters of water. This is low abdominal pressure, this is increased abdominal pressure. I did not put numbers here of aerated tissue or collapsed tissue, but you see that this very well, that the amount of collapsed non-aerated tissue here is very much increased. And the same thing happens at plateau pressure. You see that the intratidal, the recruitment is decreased, the amount of collapsed tissue increases when intra-abdominal pressure increases. It's also interesting to notice how the tidal volume is distributed. when abdominal pressure is high, the amount of tidal volume going to dorsal region decreases, while the amount of tidal volume going to ventral region increases. And it is because when the abdominal pressure increases, the amount of collapsed dorsal region increases because the diaphragm is displaced. The first thing that happens is a displacement of the dorsal regions of the diaphragm. This paper from Marco Ranieri is quite interesting. In many ARDS patients, we have a decrease in chest wall compliance. And what happens with an increased abdominal pressure, which is very common in surgical patients with ARDS, we have a decreased respiratory system compliance in red. You see this line? The slope of this line can be corrected by a surgical redo or revision of the abdomen. Sometimes the abdomen has to be left open, and you see that the slope increases because the compliance of the chest wall, which, mind you, is not made by the chest alone. The chest, what we call the chest wall, that is the container of the lung, is made indeed by the chest wall and by the diaphragm, which is contained by the abdomen pressure. So an increase in abdominal pressure decreases the chest wall compliance because it makes it stiffer. If you get your surgeon to do something on the abdomen to correct the cause of the increased abdominal pressure, then the respiratory function of your patient will increase. If we take another look at the problem, we will be able to see that the elastance of the lung is increased by definition in all ARDS patients. Elastance is the opposite of compliance. Low compliance is high elastance. High elastance means low compliance. And you see, however, that in ARDS, we very often have an increased elastance of the chest wall. In black here, chest wall, elastance is increased compared to normal subjects. Why is chest wall elastance increased in ARDS patients? At least in many of them. First of all, because in many of them we have an increased abdominal pressure. In many of them we have edema. In many of them we have good reasons to have a stiff chest wall. So we can divide ARDS patients into pulmonary ARDS and extrapulmonary ARDS. Pulmonary ARDS is mainly pneumonia. Extrapulmonary ARDS is a patient, as an example, with a septic abdomen. Patients with pneumonia, at least in the early phase, have indeed a rather normal abdominal pressure, which generates a rather normal chest wall elastance. While patients with extrapulmonary ARDS, that is, once again, a patient with a septic abdomen causing ARDS, will have indeed ARDS, but complicated by an increased abdominal pressure, which generates an increased chest wall elastance. So the respiratory system will be stiff, not only because the compliance of the lung is decreased, but also because we have indeed a decreased lung function, but also a stiffer chest wall made up also by an increased abdominal pressure. So measuring chest wall elastance is very important in ARDS patients, and is very important indeed to measure esophageal pressure to get an idea of the pressure around the lung. In summary, patients with ARDS and high intra-abdominal pressure might have a transpulmonary pressure lower than we expect. If we measure a high airway pressure in our patients, and the abdominal pressure is high, a good proportion of the airway pressure we measure is not acting on the lung, but is acting on the chest wall and the abdomen. The transpulmonary pressure, the pressure that acts on the lung, will be lower. Talmor, the group of Talmor in Boston, noticed that many patients with ARDS do indeed have esophageal pressures very high compared to normal, and that causes an esophageal pressure that is much higher than normal. That is, the abdomen displaces the diaphragm, that compresses the lung. The lung is indeed compressed. As you can see here, in this patient at baseline, the esophageal pressure is indeed negative at baseline. I'm sorry, please, the transpulmonary pressure, I better put down my glasses so I can read what is written. The transpulmonary, people get old. Transpulmonary pressure is negative at baseline. What does it mean? That the pressure across the lung is negative. Being negative means that somebody is pushing on the lung. Who's pushing on the lung? The chest wall. So even if suppose we read 3 centimeters of water airway pressure, what will be the transpulmonary pressure if the esophageal pressure is positive? 0. If I have a transpulmonary pressure of -3, it means that I have to use at least 3 centimeters of PEEP to keep the lung inflated. So they adjusted PEEP according to the pressure around the lung. They adjusted PEEP according to the possible compression around the lung, and they obtained very positive results and a good oxygenation and a signal toward better survival in spite of an obvious higher plateau pressure. In the last H1N1 influenza epidemic, we had a lot of patients undergoing ECMO, and we did a lot of patients, we treated a lot of patients with ECMO. In a few of them, though, we noticed that the abdominal pressure was high and the intrathoracic pressure was high. So rather than putting them into ECMO, we increased the airway pressure to counterbalance the increased intrathoracic pressure. And then we could treat them according to Talmor, avoiding ECMO. So, in summary, when we have a patient with increased abdominal pressure, we will have an increased chest wall elastance. That means that the respiratory system is stiff because the chest wall is stiff, not just the lung is stiff. And we can recover end expiratory volume by increasing PEEP, by increasing airway pressure. This, however, will end up in an increased intrathoracic pressure that has side effects, like a decreased cardiac output, shown here. And these authors, in a pig model of intraabdominal hypertension, found that PEEP did indeed recover end expiratory lung volume, but that was achieved by a decreased cardiac output. So in conclusion, we should find the cause of the increased abdominal pressure if we have a patient like that. If it's surgically correctable, we should correct it. If we need, we can increase PEEP to counteract the increased abdominal pressure. But we must be prepared to an hemodynamic impairment that we will have to correct with an increased blood volume. Thank you very much.